Another side effect that patients may experience is lymphedema. This is an increased buildup of lymphatic fluid in the tissues, either in the breast or in the arm and hand of the affected side. It's quite problematic for women. They might feel self-conscious. It might be uncomfortable that the arm feels like throbbing or heavy. Clothing might not fit quite right. So we're always on the lookout for that.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Maria Fenton-Kerimian, nurse practitioner at Weill Cornell Medicine in New York, about radiation site-specific side effects in breast cancer. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Welcome and thanks so much for joining us today, Maria.
Thank you.
So to begin, why might individuals with breast cancer need radiation therapy as opposed to other available treatment options? And are there certain types of breast cancer for which radiation therapy is maybe the preferred treatment modality?
Radiation therapy is typically given to improve local control within the breast itself. The goals of radiation to the breast are typically broken out into three different rationales, either adjuvant treatment, where the tumor is removed surgically from the breast first, and then radiation is delivered to lower the likelihood of a return of the cancer. And then the second way it's given is sometimes with a curative intent, and that may be for tumors that for some reason couldn't be fully resected. And the hope is to eradicate the tumor that is still present in the tissue. And lastly, it can be given in a palliative fashion where you're not really expecting to completely cure the person of the cancer, but you hope to shrink the tumor enough to relieve symptoms. I believe that the most common way that radiation might be given to the breast is that it would be adjuvant breast radiation, and that probably is the largest portion of most radiation practices. About 25 or better years ago, there was a big publication by Dr. Fisher, and that's when they first really looked at breast conservation, pairing a smaller surgery than mastectomy, namely a lumpectomy, with radiation. And what they saw is that by putting the radiation, you really lowered the risk of a local recurrence from about 25 to 30% down to the same risk as if the whole breast had been removed with a mastectomy. And this really became kind of the gold standard for adjuvant radiation therapy. Additionally, we can sometimes give radiation after mastectomy and axillary node dissection. Radiation in this situation is usually added to the mastectomy or chest wall and skin site, and also to the lymph nodes surrounding. This would typically be done if there was 3 or more breast lymph nodes, axillary lymph nodes involved. However, recently there have been several studies that have come out that have really kind of challenged that indication for radiation. And the 3 most significant ones I would mention are NSABP 51. And that trial really looked at people with N1 lymph node disease that achieved N0, no remaining lymph nodes, after neoadjuvant chemotherapy. And they were really asking if it is safe to omit that nodal radiation. And the answer was yes. If the person achieved a complete pathologic response in the nodes, there was no reason to add those additional radiation to that area. The next study that really kind of changed our practice was the Z0011 study. And in that setting of a positive sentinel node, the question was asked, is it okay to omit an additional bigger surgery of an axillary node dissection? And the answer was yes. because many of those patients with 1 or 2 positive lymph nodes that didn't have the further dissection were going to receive radiation anyway. So sometimes patients, even with 1 positive node and a limited dissection of a sentinel node, will be included to receive radiation. The third study that has really kind of changed this practice is the Supremo trial. And that study really showed that radiation isn't needed to the chest wall to improve survival if a patient has had a complete mastectomy and no lymph nodes involved in the field. So really the indication for adjuvant radiation remains people that have had a lumpectomy of any type and still have their breast tissue. They should be offered radiation therapy in the adjuvant setting, and also patients that have either 3 lymph nodes or more in the setting of an axillary node dissection, or even 1 in the setting of a sentinel node biopsy.
That's all that very interesting information. And it really just makes me appreciate how we established that something might work, but there is still much to learn about how we could do it differently and potentially make it work just as well or work even better. I know we are seeing this a little bit in some of the medical oncology therapies as well. What is the required dose? There's a maximum dose, but what's the required dose to get the same efficacy and to get the same positive outcomes? And so just hearing you talk through the different studies that have been able to inform how we can provide radiation therapy for patients with breast cancer in a more nuanced approach so that we are, being as efficacious as we can, but also trying to limit toxicities and other outcomes that we know are challenging. I think it's just really fascinating to hear how the science has evolved and what we've learned through repeated studies of just ways that we can do it differently. Let's move on to talk a little bit about some of the side effects that come with radiation when given for breast cancer. What are some of those most common short-term side effects or toxicities that we see associated with radiation, and how can these be managed?
The most common side effect I think that nearly every patient complains of to some degree is fatigue. It can be as minor as, oh, I feel like I'm falling asleep while I'm watching TV at the end of the day, to I feel so tired that I just don't even know that I can go grocery shopping for my family or get out of bed to go to work. It's quite a subjective experience, and there's many factors that go into why someone might have more fatigue than another person. It could be the individual person's other medical conditions and comorbidities. It can be prior therapies, like if they've already completed chemotherapy, or it can also just be where the person is in their life, if they're experiencing concurrent depression or other symptoms. But we really try and focus on patients managing this fatigue by ensuring that they're having an appropriate balanced diet with proper macro and micronutrients, that they're having adequate protein intake. We encourage patients to get adequate sleep. There's a culture of people pushing themselves and working into late hours of the night, and this will be quite difficult if you're experiencing radiation-induced fatigue. If someone is familiar and does regular exercise, we highly encourage them to continue that. If someone is not someone that has done much exercise and kind of has slipped into a little bit of maybe deconditioning or older or more frail, we might refer them for physical therapy or strength training to kind of rebuild some of that stamina and energy. Another side effect that patients may experience, especially if we have to radiate their axillary lymph nodes, is lymphedema. This is an increased buildup of lymphatic fluid in the tissues, either in the breast or in the arm and hand of the affected side. It's quite problematic for women. They might feel self-conscious. It might be uncomfortable that the arm feels like throbbing or heavy. Clothing might not fit quite right. So we're always on the lookout for that. And it can occur either acutely during the time of radiation, but can also come later on. So if we notice it, we'll definitely refer for physical therapy, occupational therapy, lymphedema targeted treatments. We usually will recommend anybody that is at risk for it to wear a compression garment on the arm, especially for like heavy gym days or maybe long flights or things like that. There's also a new or gaining popularity surgery where lymph nodes can be harvested from an alternative site, say maybe the groin or abdomen, and transplanted and vascularized to help drain an infected limb. There is also a small risk of lung toxicity, and this can just be maybe some loss of function of the lung if it's included in the radiation field, or it can be something a little bit more acute called radiation pneumonitis, where the person will have kind of symptoms of a mild pneumonia, cough, maybe fatigue, shortness of breath, and that is usually managed and reversed with oral steroids. However, we really see very, very little of it because of newer positioning techniques. One of these techniques is to place the patient in the prone position, which almost completely excludes the lung. Another technique, if they can't tolerate prone, is to have the patient on their back and to do something called deep inspiration breath hold, where the patient is coached into a breathing pattern and the treatment is only interrogated and delivered while they're in a phase of the respiratory cycle that the lung is falling back more. Also, for cardiac risk, treating the heart with radiation has been shown to cause muscle weakness and increase risk of coronary artery disease. But again, the positioning that we use nowadays is really overcome a lot of these side effects, so much so that we almost never see them or very infrequently. And again, the prone radiation or the deep inspiration breath hold can really overcome these side effects. Another much more common side effect is radiation dermatitis, which is an inflammation of the skin in response to an irritant, namely the radiation. And much like a sunburn can irritate the skin due to UV exposure, radiation dermatitis is an irritation of the skin because of the ionizing radiation that is being used in a therapeutic way.
So let's talk a little bit more about that radiation dermatitis. Are there key assessments that nurses should perform, or are there any strategies that nurses should just be familiar with in terms of managing dermatitis? And how can we help support our patients as they deal with this side effect?
There should definitely be key assessments that are happening at least once weekly and maybe more frequently if patients are developing it. And that would really be easy to grade because there's many grading systems. One of them is called the CTCAE grading system. It allows physicians and nurses to assess how severe the skin reactions that patients are getting. The assessment should include looking at the color changes in the skin, the presence of swelling or edema, if there's any breaks or impairment in the skin, any blisters, if there's discharge, bleeding, or pain. I think most people getting adjuvant radiation would be expected to develop at least a grade 1 or 2 radiation dermatitis. Grade 1 would really just include mostly skin color changes, erythema of the skin, and perhaps some dry flaking or desquamation of the skin. Grade 2 would be more likely to include brisker or more erythema. There may also be patchy, moist desquamation, so the skin is starting to peel. It may feel a little damp to the touch. But the key with grade 2 dermatitis is that all of these peeling or desquamation of the skin are confined to the skin folds. Grade 3 is really severe. Many clinical trials would suggest even holding treatment if it's developing. And that really would mean that the moist desquamation is extending past the skin fold so that it's really covering most of the area. There may even be like patchy spots of bleeding. And grade 4 is pretty infrequently seen, would really be a problem, but would be like full thickness, like skin necrosis, ulceration, just bleeding spontaneously. There's many things that are on the market, both in the form of prevention and treatment for radiation dermatitis. One of the key products to use for prevention are silicone patches, and there are many on the market that are worn during the course of radiation or when the skin reaction begins. And they could stay on for several days during treatment, even if you're gently showering around the area. There's many creams, homeopathic creams made from calendula flower, aloe vera, even aquaderm, or some kind of aquaphor, or some kind of combination of these type products. The real issue with these products, I think, is that many of them aren't covered by insurance. So patients have to buy them out of pocket over the counter, which for some of our patients, maybe that are more financially challenged, it may be a problem. So I think to be familiar with many different products so that patients really have access to at least something that will minimize their skin reaction. If the patient really is developing, say, like a grade 2 to 3 reaction, we might think about prescription corticosteroid creams, like a hydrocortisone or mometasone type cream, especially if there's a lot of itching. We try not to put that on open skin. If the skin is really open, kind of like damp and wet desquamation, we would usually want to use some kind of occlusive or anti-infective type cream. One that's very easy to prescribe and covered by most insurances is Silvadene cream. There's antibiotic pads like Xeroform gauze. There is other occlusive dressings that may be stocked by certain pharmacy hospital centers. If patients get up to a grade 3, I think really most doctors would consider a short treatment break. Analgesics may be necessary, like pain medications. It may be necessary to even put the patient on oral antibiotics.
Wonderful. Thank you for that very comprehensive review of dermatitis. I know that something that nurses are accustomed to seeing with our patients and helping our patients to manage. So all of those details will be very helpful. Let's talk a little bit more broadly now just about all of the side effects that you mentioned, certainly cross several different body systems. So are there other healthcare professionals that should be included as part of the team that helps to manage all of those various side effects?
Depending on the practice site, we rely a lot on our therapists. They're quite experienced. They often may be the person that brings to our attention, the nurse's attention, that a skin reaction starting. Patients are routinely seen once per week. However, if reactions are starting, it may be brought to our attention sooner by the radiation therapist. It's very preferable for patients to have a consultation with a nutritionist regarding their breast cancer diagnosis and radiation treatments. We try and have our patients seen by social work for any time off work that may be needed, financial concerns. Sometimes they don't want to say the financial burden of going through treatment. We will often refer patients to our physical therapy OT team. In very severe cases, we might bring in a wound care specialist nurse or a pain management specialist.
When you talked about dermatitis, you did reference specifically the CTCAE to help grade, kind of assess that toxicity. Are there any other key assessment tools that we should be aware of to help grade or evaluate other radiation side effects?
Yes, we will often do measurements of the arm for people that are at high risk of lymphedema. We have various quality of life questionnaires that assess certain side effects that patients may be going through. They're usually attached to clinical trials that they're on. There's a FACT-B quality of life survey that we use. Sometimes we may even take pictures of the reaction because from week to week, day to day, sometimes it's hard to really see, is this improving? Is this not?
We've talked a little bit about acutely presenting side effects. Let's move on and talk a little bit about late presentation side effects or even things that could develop into chronic side effects that patients may experience. What are some of these common late effects of radiation that patients with breast cancer might experience? And when do these typically occur?
The acute side effects, they typically say that this occurs within the first 90 days. After 90 days, it may be more common to see some of the cosmetic changes that can happen in the soft tissue of the breast. One of them is radiation fibrosis, which can kind of be like a diffuse scar tissue in the breast. It can sometimes cause hardening, retraction, asymmetry. Sometimes it can cause like a tight feeling where people can't stretch their arm to the full extent. We also know that there can be slower healing if surgery is done. So for people that say maybe have like tissue expanders or still want to have corrective plastic surgery, we really encourage them to wait at least 6 months or longer before approaching any of those plastic surgery type procedures. There is a small, very small, like less than 1% risk of secondary cancers. So we would really encourage people to have a good primary care that is doing appropriate screening over a person's lifetime, especially if they've received radiation at a younger age. The risk is highest among people below the age of 40 that receive radiation. Also, even though we don't see cardiac and lung toxicity as frequently as maybe a decade or two ago, having a good primary care doctor that will continue to monitor things like blood pressure, elevated cholesterol, and cardiac health is really important.
Are there any populations of patients that might be more vulnerable to certain radiation side effects that we've talked about?
Yes. So if a person gets radiation at a younger age, they might have a higher risk of secondary malignancies, even though it is a small risk and the benefit definitely outweighs the risk. However, there's also people that maybe have autoimmune conditions such as like lupus or rheumatoid arthritis that may have a higher sensitivity to radiation and therefore maybe a little stronger side effects. Certain drugs may heighten sensitivity to radiation, some chemotherapies, some antibiotics, smoking, alcohol use, marijuana use, all increase the risk of radiation side effects and skin reactions. There's also certain genetic carriers that may have a higher predisposition to more intense radiation side effects. These would really be people with mutations in genes for DNA repair. Sometimes we see like ATM mutations or BRCA carriers, P53 carriers may have just a slightly higher skin reaction or maybe fibrosis in the breast. We also know people with Leigh-Fermani syndrome have a higher risk of side effects from radiation. Those would be the people I would just keep an extra close eye on. It doesn't mean that we wouldn't offer radiation, we would, but perhaps we would be a little bit more alert towards the end of their course of treatment. And sometimes the dose may be adjusted at the end if we really see quite brisk of a reaction.
And we know sexual health is an important topic that we need to continue to bring up to our patients to ensure that we are assessing it and addressing it the best way that we can. What sexual health considerations do you see that are important for patients receiving radiation for breast cancer? How can we as nurses and healthcare professionals be more aware of these issues? And what are some of the ways that we can initiate those conversations to discuss sexual health with our patients?
Sexual health is such a big topic, but I think that nurses in radiation oncology are in a very good position to do that because we see the patients for a repeated period of time. So there's maybe a quicker intimacy or familiarity that happens with the nurses in radiation. Personally, I always bring it up at a follow-up visit, which we do about a month after radiation ends. And it's kind of because the dust is settling and people are maybe getting back to their life. I will always do a brief depression screen. I usually ask about safety at home because it's hard to feel intimate if, the stresses of treatment have maybe put people in a vulnerable position in their home or safety. And then I personally like to use the Arizona Sexual Health Screening Tool, And it's brief. It's like 5 questions, but it really gets at the heart of why they're experiencing maybe less than their optimal sexual health. Is it really an emotional reason that they just don't feel like it? Do they have a low libido? Is it because they're suffering from, say, like dryness and discomfort with penetration because of the lack of estrogen that much of their treatments may induce? So that's what I usually do. Once I get at why the person is feeling that way, obviously, if it's a safety issue or a depression issue, I would issue referrals to the appropriate people to help them. But if it's because they're really suffering with the lack of estrogens and vaginal dryness, I would usually prescribe or recommend vaginal lubricants. I always start off with like a non hormonal based lubricant, and it can be in the form of suppositories or creams. If that really doesn't help after, say, like a couple of weeks, we can refer them to a gynecologist or prescribe a very low dose estrogen cream to be used vaginally, or an ester ring is permitted by many of our oncologists to be placed in the cervix. Obviously, all this has to balance against how severe the breast cancer was and how much hormonal depletion they've gone through. There's also new drugs on the market now, kind of targeting low libido in women. And this has been well addressed for men over many years, but now there's drugs like filabanserin, which basically is using different types of serotonin receptor antagonists and agonists together to increase female libido in women below the age of 65. There's also support groups. Sometimes just knowing you're not the only one experiencing this is helpful. We try and target our support groups based on age. While everyone can get support from anyone, probably the issues facing, say, a woman below the age of 30 that's still dating may be different than someone that's maybe been married for 30 years and is 60 years old. So I think feeling like someone else is going through it can be quite supportive for people.
I really appreciate your commentary because it helps me think about how sometimes the person best positioned to help address or solve what maybe the underlying issue is that's impacting sexual health, it may not be me. Like I might not have the answer. I might not be able to immediately find the solution, but somebody has to ask the question and somebody needs to identify and talk with that patient to understand what are their challenges. And then as you've very nicely discussed of like, then you find out where we need to help provide that support or refer them to the right practitioner or get them in touch with a different specialist if that's truly what it needs to address their concerns. But I think the important message for all oncology nurses is to understand that their role is to always, to ask the question and to have those conversations. And as you so expertly pointed out, we have a special relationship with our patients. Radiation oncology nurses are seeing patients potentially every day for weeks on end. So that relationship provides itself a comfort to be able to ask those questions at the right time or repeat it in follow-up. And so I just think it's really important for all of our listeners to remember how important their role is in providing that assessment and asking those questions to normalize that challenges and changes in sexual health might be part of therapy, but they might be something that we can also help address. Well, Maria, thank you so much for joining us today on the podcast. As we reach the end of our episode, we'd like to always run through a series of some quick summary questions just to help capture some of the kind of larger points that we've talked about today. So to start that off, how do you think healthcare professionals can evaluate their hidden or maybe their implicit bias about radiation therapy given for breast cancer?
Obviously, everyone's bias is different. Personally, I put a lot of patients on clinical trials. I always ask myself, would I do this treatment if I was in this situation? And I kind of ask myself, if I had to do this, what would I be afraid of? And I think maybe kind of coming back to that and just asking patients those type of questions may help even bring your own biases to light. I often ask patients, I've told you all about this treatment. What are you afraid of, or what are your thoughts? And then I take it from there.
What are some common misconceptions about radiation therapy for breast cancer?
over the years, I've heard from many patients a real fear that they're going to develop cancer from getting the treatment. That's really a very, very, very small group of people that can get cancer from their treatment. And it's getting less all the time with more advanced positioning and more targeted treatments. Patients are very afraid that they're going to hurt their family, that they'll be radioactive in some way, that they'll carry the radiation with them to, say, grandchildren or their pregnant daughter or whatever the case is. People also have a misconception that they can only have radiation once. I've had patients pass on it and recur because they said they wanted to save it in case they really needed it in the future. But best opportunity is early to prevent a recurrence from happening.
What's something about this topic that's not often discussed, but you wish people knew more about?
Just how much it's really changed. I've been in radiation for almost 25 years. When I started, almost every patient received 6 to 6.5 weeks of therapy. Many patients now can get as few as 3 weeks, even 1 week of treatment. It's really quick to deliver. They'll often be in the department for less than half an hour a day, maybe even some people 15 minutes. So I think people are really fearful that it's going to be so disruptive to their life, but it's really improved in terms of that.
What additional training or education do you think oncology nurses need to help stay current on this topic?
There's so much changing so quickly. I think it's really important for nurses to maybe do like a yearly check-in and see where the indications for treatment are going. National conferences are a great way to go. Our national conference for radiation is called ASTRO, and you can really see new studies that have come up. Also, ASCO is a great one to go to nationally and annually, and of course, ONS. So any of those kinds of sites to try and get to, even if you're reviewing the information online, would be something that I would do maybe like a once a year check-in and kind of updating myself on the types of patients I see, what were their critical studies that have come out in that area.
And finally, what are some additional resources that you might recommend, maybe for patients or even other providers who want to learn more?
I usually recommend the NCCN guidelines for treatment. Often when I precept NPs or nurses, I will say, if you don't know why something's being done that seems different, go to the guidelines, see what's recommended, and then ask your provider, why are we not giving axillary radiation to this person? It may be that a new study just broke and we're omitting because it showed that there's not an indication anymore. So knowing what the standard is in something like NCCN and then seeing where things are different and questioning why things are different, because that's how you'll learn what the next new study is if you're not familiar with it on your own at that point. I think everybody is happy to share that knowledge discussion.
Well, Maria, thank you again for joining us today on the podcast and sharing all of this great information about radiation when given for breast cancer. I've certainly learned a lot.
Thank you for the opportunity.
Thank you so much. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.